Hey everyone, and welcome. Today we're going to jump into a really practical, evidence-based playbook on our role as pharmacists in the primary prevention of atherosclerotic cardiovascular disease, ASCVD. This is all about giving you the key plays you can use in your practice, like tomorrow.
So, first things first, what are we actually talking about here? Primary prevention. It's all about being proactive. It's the work we do to spot that risk and step in before a patient ever has a heart attack or a stroke. The goal is to keep them healthy right from the start.
And that really leads to the big question for all of us, doesn't it? As pharmacists, right there on the front lines, where do we fit into this picture? And how can we make the biggest possible impact for our patients?
Well, the evidence couldn't be clearer. The source material for this whole explainer points out that we are not just dispensing meds. We are key players who have a proven track record of effectively helping patients get their cardiovascular risk down. That's huge.
Okay, so let's get into the playbook. Our very first play is all about identifying and assessing. I mean, you can't manage a risk if you don't even know it's there, right? So let's break down how we screen and stratify.
So for our patients in that 40 to 75 age range, a global cardiovascular risk assessment should really be on our radar every 5 years. And this table here kind of lays out what we're looking for. And it's stuff we see every single day. Checking a blood pressure at every appropriate visit, making sure they've had a lipid panel in the last 5 years, simple stuff.
And the process itself, it's a pretty straightforward 3-step play. First, you assess those key risk factors. Second, you make it official by calculating their 10-year risk with a tool like the Framingham Risk Score. And then, step 3, you use that score to stratify the patient into a category.
And here's what that looks like. This is how that score translates into clear, really actionable categories. A score of 10% or less, that's low risk. 11 to 19% is intermediate. And anything 20% or higher, that puts a patient squarely in the high-risk category for having an event in the next 10 years. And this stratification, this is what's going to guide how intensely we intervene.
All right, next up, the foundation. The absolute cornerstone of any prevention strategy is helping our patients build and maintain healthy behaviors. This is where it all starts.
Okay, look at this number, 30%. So what is that? Well, that is the approximate reduction in heart attacks, strokes, and cardiovascular death that we see in studies of the Mediterranean diet. That is an incredibly powerful counseling point to have in your back pocket.
And it's not just diet, of course. These are the other big lifestyle targets we can be reinforcing every day. We're talking about shooting for at least 150 minutes of moderate to vigorous physical activity a week, cutting back on sodium, limiting alcohol, and obviously, always being ready to offer support for smoking cessation.
And now for the question we probably all get a dozen times a day. You know the one. The patient walks up to the counter, holding a bottle of some supplement, and asks, "Will this help my heart?" So what does the evidence actually tell us?
Let's be really clear here, because our patients need us to be. For all those antioxidant supplements, things like vitamin E, vitamin C, beta-carotene, the data just isn't there. There is no proven benefit for reducing vascular risk, period.
And you know what? The same goes for these others. Homocysteine-lowering vitamins like folic acid and B12, nope, they haven't been shown to reduce risk. And this is a big one. For primary prevention, the evidence also does not support a benefit for omega-3 fatty acid supplements. Our counsel really needs to be focused on what works, evidence-based lifestyle changes, and pharmacotherapy.
Okay, on to our next play, pharmacotherapy. So when lifestyle just isn't cutting it, we have to start a more nuanced conversation. And this one has to be all about that crucial balance of risk versus benefit.
Now, if you really want to talk about risk and benefit effectively, concepts like number needed to treat and number needed to harm are just invaluable. So let's look at the numbers for two heavy hitters in primary prevention, statins and aspirin.
For statins, the number to remember is 52. That's the number needed to treat. It means we need to treat 52 people with a statin for 2 to 5 years just to prevent one major adverse cardiovascular event. See? This is how we can put that benefit into a real-world perspective for our patients.
And when we talk about the risks, we got to be specific. Serious side effects are pretty rare, but the most common thing patients report with statins is myalgia, muscle pain. That is a super important counseling point, so patients know what to look out for and when to talk to us about it.
Now this slide really just lays out the central dilemma with aspirin and primary prevention. To prevent one major CV event, we have to treat 241 people. Okay, but to cause one major bleed, we only need to treat 210 people. The benefit and the harm are practically neck and neck. And that's exactly why shared decision-making is absolutely essential here.
And that shared decision-making all comes down to our risk assessment. Before a patient even thinks about starting or continuing aspirin, we have to be actively screening for these bleeding risk factors. I'm talking about a history of GI bleeds, being over 70, or taking other meds like NSAIDs at the same time. These things dramatically tip that risk-benefit scale away from any benefit.
So, how do we take all this data and actually use it in a real conversation with a real patient? Well, that brings us to our final play, putting it all together with some key counseling takeaways.
This is it. This is the question we hear all the time, right? The patient who feels great, is totally asymptomatic, and is really hesitant to start a medication for the long haul. How do we even begin to approach that conversation?
The answer is shared decision-making. We have to frame the benefit not as lowering your cholesterol number, but as preventing a future heart attack or stroke. We've got to discuss the risks and side effects honestly. And it is so critical to stress that these meds only work if you take them long-term. And using decision aids to help a patient actually see their personal risk can be a total game changer.
And let's all try to remember this fundamental idea. Every single time we talk to a patient, doesn't matter if it's for a refill, a flu shot, whatever, it's an opportunity. An opportunity to identify risk, to start a conversation, and to encourage them to make progress.
So I'm going to leave you with this one question to take back to your pharmacy. In your very next patient encounter, what's one thing from this playbook? Maybe it's asking about screening, maybe it's explaining the NNT for a statin, or just debunking a supplement myth. What's that one piece you're going to use to change the conversation about prevention? Thanks for tuning in.